Great. Well, thanks, Marla. And again, thanks for everybody coming out on a sunny Saturday in Boston. I was asked at one of these recent talks to try to put together a number of the data slides you heard earlier this morning from Russ and from Adam and put it in the context of the practice. So I'm going to spend a few slides on therapeutic drug monitoring. We have a whole case on that, and Adam can comment on that as well, but then also give you my perspective on positioning the new therapies, the biologics, the small molecules, and IBD. So these are my disclosures. Despite moving to Cleveland a year ago from Pittsburgh, I am still asked this question, so I feel that I have to continue to show this slide that yes, I am still a Pittsburgh Steelers fan, even though I now live and reside in Cleveland. So beyond combination therapy, the therapeutic drug monitoring, really we've talked about some of this already. I'll show you some of the TAXIT data. I'll tell you up front that Adam's given me most of the slides I'm going to show in the next few minutes. Proactive versus reactive checking, post-induction therapeutic drug monitoring, and how then to position these in practice. The only thing I'll mention up front is we have a number of biologically active agents now, but I would submit, even though we talked about levels with Vito and with ustekinumab, really the therapeutic drug levels we're most interested in revolve around infliximab primarily and then adalimumab secondarily, but we'll have a discussion at the panel. So what's the TAXIT study? And this is probably one of the better studies looking at proactive testing in IBD. And these were in patients who have been on infliximab and had a clinical response. The patients underwent infliximab testing with dose optimization, and you heard it on the panel that probably we want to get closer to 10. Nonetheless, in this study, dose optimization was trying to get into a range between 3 and 7 on the infliximab concentration. So patients were randomized either to what we would consider maybe standard non-therapeutic drug monitoring care, checking CRP, following clinical symptoms, and optimizing dosing blind to therapeutic drug levels, versus checking therapeutic drug levels and then proactively switching the dose based on the number. And the primary outcome was clinical remission at 1 year. What you can see here on the left-hand side, in red is after dose escalation, blue is before dose escalation, and the left-hand side is looking at clinical remission. For ulcerative colitis, there's no difference, but in Crohn's disease, where you see the red circle, there was a difference between dose escalation after dose escalation versus before in terms of clinical remission. Similarly, there was a drop in the C-reactive protein after dose escalation. So interestingly though, in the TAXIT study, as the primary outcome was considered negative, and I show you the Kaplan-Meier curve here. There was no difference in remission rates between those that followed therapeutic drug monitoring and those that were clinically dosed. However, I think a few important caveats. So all patients were initially optimized. We only followed these patients for a year. And the question is, should we actually be aiming for a target of not 3 to 5, 3 to 7, but more in the order of 10? However, there were a number of secondary endpoints that showed a benefit when we used proactive therapeutic drug levels. So it's interesting, when I asked all of you at the last case, how many of you are doing this already, especially after induction, many of you raised your hand. So I think the message is being delivered, even though technically the TAXIT primary endpoint was negative. Adam's group here in Boston then looked at a proactive therapeutic drug monitoring versus standard of care. Now this was a retrospective design, but nonetheless he took patients that he followed and used proactive testing. So for those that don't know, Adam Shafitz is wild about proactive therapeutic drug levels. So you must live under a rock not to know this by this point. So he'll sit up here and tell us that in a minute. But then his partners were not necessarily as wild as he was in terms of checking levels, and they basically didn't necessarily check proactively. And you can see the schema here in terms of what was done if the level was either undetectable or low, and then the algorithm by which he took patients through if the levels were low. Interestingly, he also looked at de-escalation. So for those patients that had high levels, maybe decreasing from 10 milligram per kilogram down to 5 milligram per kilogram. And what he eloquently showed was in the blue is the therapeutic concentration monitoring, essentially proactive TDM, versus those that did not have proactive TDM. And you can see a nice separation between the lines. So even though retrospective, off of his cohort of patients at Beth Israel, this was a positive study. And then the other area that I think therapeutic drug levels come up is, what do we do post-induction? This is probably what I would argue the most important time. So you give that 3-dose induction, or you give the adalimumab induction, and then you measure a dose. And what was found here is, interestingly, in the third bullet point, the patients who had concentration levels at week 6 that were higher than non-responders actually overall had a better outcome. So there's early evidence, if we check proactively, we may actually make a difference. So where do I see TDM playing a role, and how would I position this in practice? Well, certainly I think reactive testing for those that are not proactively testing. If you have a patient who's losing a response, especially to infliximab and adalimumab, I think checking levels then and certainly seeing if they have antibodies makes sense. And I think most of us have been doing that for a while. The other part is proactive therapeutic drug levels in a maintenance setting. So can we optimize monotherapy, keep patients on drug longer, even if they're feeling well, and dose adjust into a range of, say, 5 to 10? If we stop, if they have been on a concomitant immunomodulator, it would behoove us to check levels before stopping that immunomodulator, because the reality is if we stop, the concentration of the anti-TNF goes down, or they start to develop antibodies. We want to check a pre, and then we want to check a post level to make adjustments from that. And then I think the area that I just mentioned that most of us and many of us are doing, certainly in sick UC and in Crohn's, is that proactive testing after the first induction course of infliximab or adalimumab, and then using that to measure and then alter therapy long term. There are certainly gaps in our knowledge around therapeutic drug monitoring. One, you heard a minute ago that there are different labs sending this, so what's the accuracy? Can we have accessibility? So the question was raised about cost, and some of these need to be more inexpensive. Now, Adam mentioned that $75 out of pocket may be the reality cost, but for some patients, that's still prohibitive. And we do need still more prospective data, which will come. So let me switch gears now and talk about one of the questions, and how do we position our current therapies? So I put the 4 biologically active classes up: anti-TNF, the integrin, IL-12/23, and the JAK inhibitors. So we're evolving in the way we treat this, and you heard from both Russ and Adam already some of this, so I won't repeat everything, except to say for ulcerative colitis, we've gone beyond the far left-hand side of this slide with just subjective scores and symptoms. However, PRO, patient-reported outcome for ulcerative colitis, diarrhea and bleeding, probably those 2 factors alone are symptom enough to at least give us some information without some of the more complex scores we've used in the past. We do now know, and I think Russ mentioned, that we want more objective outcomes of response, and now the question is, on the far right, are we actually driving the target towards histologic healing? And I would just say, stay tuned. I don't think we're there today, but in the future the question is, should we optimize, at least optimize treatment if there's histologic activity? So you've seen the picture of this patient before, and I won't take you through the whole case, but I presented this before, this 24-year-old who presents with fairly severe ulcerative colitis. In your practices, you do this all the time, but interestingly, there's been by the AGA, and I think both Russ and Adam mentioned this, a tool now, a decision tool, and if we don't like these decision tools, the other people who, by the way, use these are the insurance companies. And you better believe that the insurance companies are starting to follow this in terms of guidance, in terms of which therapies, whether we like that or not. So this is the AGA decision tool for ulcerative colitis. I think, Russ, you were involved and I was involved in putting some of this together, and some of this is fairly basic. The main question though, and I think this is more useful to look at, is what are the high risk factors in ulcerative colitis for colectomy? And I put, by the way, the www up there if you wanted to see the decision tools by the AGA. I would split ulcerative colitis into two flavors. On the left-hand side is the low-risk patient, which in ulcerative colitis is about 50% of the patients. And by the way, when I say a high risk factor for colectomy, I would also put in parentheses, these are the patients we should start early biologic therapy. So the those that are high risk factor. The low risk factor patients, the mild patients you see in your practices, absolutely oral 5-ASA with or without rectally administered 5-ASA is okay. On the right-hand side, deep ulcers, if you were to remember one risk factor, deep ulcers are a high risk factor for UC and a colectomy. So Russ put this up, and I think we talked about this. I added a little bit at the bottom though, so this is outdated already, okay? So we had initially said a short course of steroids with thiopurines. One, I think we now realize that thiopurines probably play no role, certainly in the induction treatment for ulcerative colitis, and I would argue probably not in maintenance as well. So what does that really leave us? That leaves us with the anti-TNFs with or without combination, vedolizumab, and then I put tofacitinib at the bottom. At the very bottom, coming soon, is probably going to be ustekinumab. So we're going to have several agents and options for ulcerative colitis treatment. The varsity study's already been discussed, but just to highlight, this is the first comparative effective study, and this did show, at least in this study, that vedolizumab did outperform adalimumab for ulcerative colitis. This has been submitted to the New England Journal of Medicine, and we'll wait and see what happens as far as where this gets published. What about the very high risk? We talked about inpatient briefly, and I just want to touch on this for a minute. And I think Russ mentioned this in terms of one treatment option we don't usually consider, but it's certainly reasonable. So IV steroids and infliximab, but certainly IV cyclosporin. The question will become, where does tofacitinib play a role in the inpatient? And maybe we'll have a discussion on the panel about this, but the University of Michigan group, and I'm about to say information that I'm not necessarily suggesting we do, but is looking at actually 10 milligram 3 times a day of tofacitinib in inpatient, off-label, and I'll make that caveat. The question, though, is a small molecule that's not excreted in the stool as a monoclonal antibody, would tofacitinib play a role? And the answer is it may, and that might be a unique opportunity for us to consider. This is an algorithm. I think Hans Herfarth maybe gave me this way back, and I've actually modified it. I think a couple of take-home messages for inpatient UC. The days are gone that we sit on a UC patient on steroids, in my opinion, more than 2 days. We used to say 7 days. Realize many of these patients come in already on oral steroids and failing oral steroids, and we need to act much faster. So we get our surgeons involved, we check for C. diff, we do the CMV checking. We're already getting the Hep B, we're sending our quantiferin gold or doing our PPD on day 1. And by the way, I use a pediatric colonoscope, unprepped pediatric colonoscope in the patients with bad UC. Why? They're already auto-prepped. They're coming in with 20, 30 bowel movements a day. You don't need to give them a prep to clean them out. 2 is pediatric colonoscope. If I get to the sigmoid, it looks terrible, I stop. It's a flexible sigmoidoscopy. I get biopsies for CMV and I come out. If it's going smoothly though, and I'm thinking the patient may need a J pouch and wondering about backwash ileitis, I will continue and try to get into the ileum. So I think that that's one caveat to maybe change the way we used to do things. Then the question is, if they're not responding, the surgeon's seeing them with you from day 1, you're talking about colectomy, which is not a failure. Some of our patients need colectomy, but then it comes down to what are your options. Cyclosporin, probably in Chicago, that would be first choice if they haven't been on anything. Infliximab, Marla mentioned 10 milligram per kilogram, which is what I would do in these patients, and we will usually redose within a few days if they're not responding. Take-home message number 2. If a patient fails 2 10 milligram per kilogram doses of infliximab within 5 days of being hospitalized, they go to a colectomy. I don't mess around with anything else. I don't put them on cyclosporin. I don't put them on TOFA. They go to surgery. In my opinion, that's a patient that has a bad outcome if we don't act soon. And then finally, the tofacitinib question's there, and we don't have an answer yet. So what about Crohn's disease? And I'm not going to take you through all of the same algorithm except to say that the patient-reported outcomes are more pain and diarrhea, but the other similar concepts with ulcerative colitis. So this 23-year-old who has ileocolonic Crohn's that I presented on prednisone and high CRP, you're wondering, okay, what's our first-line option? Well, we break their down into Crohn's low and high risk again. High risk for surgery, but really these are the patients who need biologics. One difference between Crohn's and UC, and I put in kind of orange, hard to see on the right-hand side, is 75% of Crohn's patients are high risk. Ulcerative colitis is about 50-50. On the left-hand side, are there some patients, either screening colonoscopy or mild symptoms, you pop in their ileum, they have very mild disease, maybe a short course of budesonide is reasonable, maybe we leave them alone, maybe we don't need to escalate, but 75% need more aggressive therapy. So then the question is, we need to take into account safety, and I'm just going to end with a couple slides here. I was asked to show my pyramids, so I'll show them again. This question about where do we position medicines in terms of safety? So this was my old pyramid that I put the top of the pyramid is the safest. Now I should mention again for the millionth time when I give this talk, this is my pyramid. I made it up. It's not evidence-based. This is just how I look at the safety and when I talk to patients about this. But it doesn't mean that the lowest part of the pyramid, combination anti-TNF and immunomodulator, is a wrong treatment. There are patients who need that. This is just simply how I would look at safety. Now, one thing that I changed though, and I think that this is based on more data that's come out, is that I think vedolizumab and ustekinumab should be put on par. Ustekinumab safety data has looked very good. I would say that it is comparable to vedolizumab, even though we say vedolizumab gut selective. I really think the safety based on the data we have so far. But I'd put at the very bottom, and Adam said this, corticosteroids, and I'd also make the statement that under treatment of patients is also a bad outcome, and we need to optimize treatment because if we don't, there are bad things that can happen. In the bottom right-hand side of this slide, Marla mentioned MACE, this cardiovascular phenomenon. We know that inflammatory IBD itself is thromboembolic. Forget medicines for a minute. So we've seen cerebral vascular accidents, portal vein thrombosis. I saw a guy with bad UC, not on medicines, who had portal vein clot. PEs and MIs even have been linked to this. So we need to control the inflammation. So I'll just end. I have 3 more slides. This is how I position therapy. So I look at ulcerative colitis, and these are the 3 categories we have: anti-TNF, anti-Integrin, and JAK. So on the far left-hand side, infliximab, adalimumab, golimumab are the 3 anti-TNFs for UC. We have intravenous and subcutaneous options. We know the rapid onset, especially with IV infliximab. These are easy to optimize, and we have best success with immunomodulators, but as you heard earlier, maybe we use proactive TDM in these patients. However, infections and lymphoma do need to be taken into account with our anti-TNFs. What about the JAK inhibitors? One great advantage, at least for most of our patients, is these are orally dosed. Very rapid onset, you heard sometimes up to 3 days, monotherapy, no immunogenicity, you can stop and start, maintenance dosing, and then the question is, as Marla said, do you lower to 10 milligrams a day, which is what I do if somebody's doing well after 6 months, but definitely after a year. The infection risk zoster, certainly we want to give Shingrix prior to giving this. The pulmonary embolism story has only been reported in RA, and it's only been reported at the higher doses over 50 and those that have cardiovascular side effects. So the majority of our patients that we see, they're young and otherwise healthy. I would not limit giving tofacitinib to a young, healthy patient with bad UC. Lymphoma I put as a question mark from the studies, but I'm not sure that that's going to pan out. The anti-integrins, vedolizumab, certainly we consider this the safest. It's IV. There's sub-Q coming soon. Probably in 2020 you're going to see a subcutaneous vedolizumab. Low immunogenicity, fast onset, monotherapy, and then you heard vedolizumab versus adalimumab in Varsity, and the long-term safety looks good. Crohn's disease, similar themes for anti-TNFs, just a different combination study. Vedolizumab in Crohn's does work. Vedolizumab in Crohn's does work, especially if it's first-line therapy. After an anti-TNF, we see an attenuated response. Low immunogenicity, as Russ had said, and we already talked about safety. What about ustekinumab for Crohn's disease? We didn't spend as much time, but a highly effective, very safe, very fast-acting medicine that not only heals the mucosa, but has histologic improvement as well. It also works not only those naive to an anti-TNF, but if they failed an anti-TNF. So this is an interesting factor as well from the studies. Excellent safety profile, very low immunogenicity, and it works for psoriasis. So I'm going to leave you with this. This is my clinical practice, so this is how I treat. So I always say that because I worry that evidence-based data, this is just how I do it. Now I put up there insurance dictates, and I think the reality of life is that often drives what our first decision is. So very sick UC, I still use infliximab first line. I do tend to use combination. I might differ from some of my panelists, and I do usually use it for two different mechanisms of action and immunogenicity. Tofacitinib may be very good in inpatients. We still need more data. Loss of response to anti-TNF if anti-TNF was first. If it's a secondary loss of response, patient did well for a long time, and if they were on sub-Q anti-TNF, I will switch them to IV. However, if they're on infliximab first, they've done well and they lose response to infliximab, with other options now, in my practice, I'm switching out of class. If they're a primary loss of response, then certainly we switch out of class. We don't go to a second anti-TNF. That UC outpatient, if they're over the age of 60, I certainly think vedolizumab, as Adam said, monotherapy first line, maybe ustekinumab monotherapy. That's not yet approved, but soon should be. Under 60, same theme, except we have some more options. So vedolizumab, tofa, anti-TNF, and soon to come ustekinumab. Crohn's disease without fistula in one segment of the bowel, I think honestly vedolizumab or ustekinumab would be a very reasonable first-line option for Crohn's disease. If they have more extensive disease, fistulizing disease, I will use infliximab in combination with the thiopurine or methotrexate. And then under 60, again, the same message, vedo or ustekinumab. And then anti-TNF, I'll be honest, if it's a single segment Crohn's, I'm starting to, if the insurance, remember the top of the slide, approves it, ustekinumab or vedo first. Extraintestinal manifestations, well, if it's related to the gut, really you can use anything. However, I put pyoderma, uveitis, central arthritis. Anti-TNF, in my opinion, still has the best benefit, although ustekinumab may be as well. And then finally, in pregnancy, probably any of the monoclonal antibodies are okay. Obviously not methotrexate. Tofacitinib, right now in my practice until we have more data, I'm holding it for 3 months before conception. Marla might have more input, but UMA's also looking at possibly second or third trimester using tofacitinib in select patients. I'm not doing that yet. I'm avoiding it currently in pregnancy. But as with anything, we need to adapt and change with the times. Thank you very much.